Good evening, everyone. Good evening, sir. Is my screen visible?
Yes,
Okay.
Well, Dr. Dixit, I will be discussing the case in between also.
Okay, sir.
So usually what we do is discuss at the end,
Okay,
but
sir.
I think it will be better if we do certain discussions in between also,
Okay, sir.
right?
Okay, sir. So, today I am going to present a case of frequently relapsing nephrotic syndrome, which was presented to the Gangaram Hospital 1 week back. So, this is a case of Master P, who is a 9-year-old male child, and the information was given by mother, and the history is reliable. The child was hospitalized on 5th of July 26 and he was examined on the next day of admission. Child is a known case of nephrotic syndrome and now he is presented with the complaints of fever for last 3 days, cough and cold last 3 days, vomiting for 2 days, puffiness around the eyes for 2 days and 1 day for loose stools. And from the last 3 days, mother had noticed 3 plus proteinuria in the dipstick who were checking at home. History of presenting complaints. The child was apparently well until 3 days prior to the hospitalization when he developed acute onset of high grade fever with a maximum documented temperature of 104 degree Fahrenheit, and the fever was associated with chills and rigor. The fever was not associated with any rash and it was relieved with the oral medication. Child also developed dry cough for the past 2 days with no diurnal variation, and the cough was non-spasmodic and it was associated with rhinorrhea and nasal blockage. Child also had 2 to 3 episodes of vomiting that were non-bilious, non-projectile, and it was containing food particles. Child developed puffiness around the eyes for the past 2 days, which was insidious in onset and it was gradually progressive. From initially that involves only the periorbital region and later on it includes the whole face and more during the morning hours and then decreases as the day progresses. Also, the urine frequency and the amount of urine was reduced for the past 2 days and the urine was dark in color. Then on the next day, mother noticed there was a swelling of the bilateral lower limbs involving only the feet. And on the day of admission, before hospitalization, he developed acute onset 4 to 5 episodes of loose watery stools that does not contain any blood or mucus. Mother was checking the urine proteins via dipstick method at home that showed 3 plus reading for the last 3 days. There was no any history that was suggestive of increased frequency urination or burning micturition. There was no history of severe abdominal pain, abdominal distension, or blood in stools. There was no history of any flank pain, unilateral limb swelling, or limb pain. There was no history of fast breathing, respiratory distress, orthopnea, or chest pain. There was no history of headache, visual disturbances, seizure, or any altered sensorium. There was no history of any excessive weight gain in the recent time, diminution of vision, or any fracture history or behavioral changes. Past history.
Dixit, can you explain the reasons for taking these points in the history?
Yes, sir. I have asked for frequency, urgency, and maturation to rule out the urinary tract infection as child is already a known case of nephrotic syndrome and now he is presented with the complaints of fever and upper respiratory and GI symptoms. And the history of abdominal pain, abdominal distension, and blood in stool I have asked because uh, bacterial peritonitis is a very common complication in the nephrotic syndrome. So to look for that, I have asked that history. And no history of flank pain, unilateral limb swelling, or limb pain. I have asked to for the deep vein thrombosis or any renal vein thrombosis that present with the with this kind of symptoms. And fast breathing, respiratory distress, or chest pain, I have asked that symptoms for any pneumonia or any pleural effusion is there or not. And for headache, visual disturbances, seizure, and altered sensorium, I asked for these features are suggestive of any cortical vein thrombosis or if any meningitis is there or not, which is a common complication in the nephrotic syndrome. And the excessive weight gain, diminution of vision, fracture, and behavioral changes, these are the symptoms that are suggestive of steroid toxicity, and the steroid is commonly used for the treatment of nephrotic syndrome. So that's why I have asked that history.
Okay, you can proceed.
Past history. Child was diagnosed with the steroid sensitive nephrotic syndrome in October 21, and that was the first episode of nephrotic syndrome. And at the time, he achieved the complete remission with the steroid therapy. Subsequently, he developed multiple relapses in the 2022 to 2024. The records were not available, but as per mother, child developed 5 to 6 relapse episodes in the 2 years, which were treated with the full doses of steroids. And in the 2024, because of the multiple relapses child had, he was treated with the cyclophosphamide, and it was given for 3 months from July to September. And in the 2025, he had 3 relapses, and the relapses were associated with infection. And as the infection resolved, the proteinuria will also be resolved, and that relapses were treated with the stress dose of steroid. And after that, now child is presented with the current relapse episodes. There is no any antenatal birth history or neonatal significant history is present. Family history. Child is born by non-consanguineous marriage, and there is no any family history of steroid resistance or congenital nephrotic syndrome in the family. And the child had two siblings, and they both are twins, and the one sibling, twin one, has steroid sensitive nephrotic syndrome, and the pattern is infrequently relapsing nephrotic syndrome. Developmental history. Child has achieved all the milestone and he is studying in the fourth standard and he is average in study. Nutritional history. Family belongs to the non-vegetarian, and they take non-vegetarian and vegetarian diet, and the salt intake is normal, but as the proteinuria is coming in the dipstick, so mother had reduced the salt intake from the last 3 days. And the calorie and protein are calculated as per 24-hour recall method, and the calculation is pre-morbid condition. And calorie, child was taking 1530 kilocalorie, which were 7.3% deficit as per the requirement, and proteins are 22.5% deficit as per the requirement. Immunization history. Child is immunized as per the national immunization schedule, and the vaccination chart was not available with the mother. And last vaccine child received at 1.5 years of age, and after that child did not receive vaccination. So the 5-year vaccine is pending, and the child did not take any optional vaccine. Socioeconomic history. Family belongs to the middle class as per the Kuppuswamy scale. Summary. 9-year-old male child born to a non-consanguineous marriage, non-case of frequently relapsing nephrotic syndrome, presented with the fever, upper respiratory tract symptoms, and gastroenteritis with periorbital edema and persistent 3 plus proteinuria from last 3 days, which they were checking in the home urine dipstick method, which was suggestive of a relapse likely precipitated by an acute viral illness. He also had an history of multiple relapses and had received a cyclophosphamide in 2024. There was no history suggestive of steroid resistance, steroid toxicity, or any complications of nephrotic syndrome. One sibling is also affected with steroid sensitive nephrotic syndrome, and 5-year vaccination is pending for the child, and child did not receive any optional vaccines. So based on the history, my probable diagnosis is frequently relapsing nephrotic syndrome presented with the relapse with upper respiratory tract infection and acute gastroenteritis, and most probably the relapse is infection triggered.
Dr. Dixit, the patient had received cyclophosphamide.
Yes, sir.
Any indication for that, and what was the dose and what was the duration? The
Sir.
reason for asking is whether he received adequate dose or not,
Yes,
and
sir.
whether he received it for adequate duration or not.
Yes, sir.
Because both these
Cyclophos.
things are very important. As in spite of cyclophosphamide, he is still relapsing.
Yes, sir. Uh, child was child was having multiple relapse episodes, so child was fitting as per the definition of frequently relapsing nephrotic syndrome, and because of multiple relapses, steroid sparing as a part of steroid sparing agent, cyclophosphamide was given, and it was given for 3 months, and the dose is 5 mg per kg per day, and after the
What
child
was what
received
was what was the dose you mentioned?
5 mg per kg per day.
No, no, 5 mg is high dose. It is not 5. It's 2 to 2.5, right?
Okay, sir.
Okay.
Can
I
I?
think once we go on to the management,
Yes,
then
sir.
we can discuss about how and why this cyclophosphamide was given at this time and what were the other alternatives which could have been used, right?
Yes,
So
sir.
once we reach the management stage, then we will discuss.
Yes, sir.
You can proceed.
General examination. Child was conscious and oriented at the time of examination, and he was examined in the supine position. Periorbital and feet edema was present at the time of examination, and that was a pitting edema, and 2 pitting edema was present. There was no pallor, icterus, cyanosis, clubbing, or any lymphadenopathy. BCG scar marks was present over the left upper arm, and there was no any sign of dehydration.
How do you grade edema?
Sir, edema is grade based on the depth of the pitting edema. In the pitting edema, based on the depth, it was graded as +1, +2, +3, +4. +1 is less than 2 size, and +2 means 2 to 4 size. +3 is 4 to 6 size, and +4 means 8 or more than 8 size. And other
Plus
than
4
that,
means more than 1 centimeter, right?
yes, sir.
Once it is 4 plus, it corresponds to the depression is around 1 centimeter. Okay.
Yes, sir.
So, you see, actually you cannot measure it is 1 centimeter or 8 millimeter, but at least you have some idea. It is very deep and it is 4 plus. And if it is there is no depression at all, it is normal, and a slight depression which disappears quickly. That is 1 plus. And 2 plus is that depression lasts for a few seconds. And 3 plus is the depression lasts for 10 to 30 seconds. And 4 plus is the depression is lasting for more than 30 seconds. So these are some more additional criteria which you can add to your measurements. Okay. So
Yes, sir.
this is one way of classification. Another,
Another way, sir, it is classified as mild, moderate, and severe if it involves only the feet or ankle edema, then it is considered as a mild edema. And in moderate edema, there will be involvement of the ankle or lower legs or arms involvement is there. And in severe edema, there will be involvement of lower limbs, feet, arm, and facial edema.
any relationship to the weight? Because in this situation, it is very important to know the dry weight also. And
Yes, sir.
as the
Based.
patient is being already a known case and being followed up in the OPD, so it's not difficult to get the dry weight. Then you can compare the dry weight and the present weight, and then you can come to a conclusion whether this is mild, moderate, or severe. So
Yes,
mild
sir.
is
Based. Yes, sir.
less than.
Mild is less than 7% weight gain as per the pre-morbid and after edematous weight. And the moderate is 8 to 15%, and severe is more than 15% weight gain.
Okay, you can proceed.
Vital's temperature was 101.5 Fahrenheit, which was measured in the right axilla. Pulse rate was 108, which was regular in rhythm, normal volume, no radio-radial delay, and it was felt in the all peripheries. Respiratory rate was 20 per minute and regular rhythm, thoracoabdominal type. Blood pressure was 98 by 70 mmHg, which was measured in the right upper arm in supine position, and it is falling between the 50th and 90th percentile as per the AAP blood pressure percentile chart. And CRT is less than 2 seconds. SpO2 was 98 to 99% on room air. Head to toe examination. There was no cosyngoid facie. Eyes, periorbital edema were present, and there was no any pallor or icterus. Oral cavity was moist. There was no any oral ulcer or tonsils were not enlarged. Ears, so no ear discharge. There was no any nasal congestion, or there is a only clear rhinorrhea was present. No cervical lymphadenopathy. Buffalo hump was not present. No any skin rashes or stria were present. Bilateral edema of the feet were present. Anthropometry. Current weight at the time of admission of the child is 27.4 kg, which is falling between 25th and 50th percentile. Pre-morbid weight, which was available 1 month back, which is 26.8 kg. Height was 133 centimeter, and BMI as per the pre-morbid weight is 15.15 kg per meter square, and it was falling between 25th to 50th percentile. And as per the IAP 2015 growth chart for boys, the growth is normal for his age and sex, and uh, child has gained 2.2% weight, which is falling as per the classification in the mild edematous weight gain. Systemic examination, GIT inspection. Abdomen was not distended and it was moving normally with the respiration. Umbilicus was central and inverted. There is no visible dilated veins or any scar marks or stria were present. Hernial orifices were at normal, and external genitalia showed no any scrotal swelling. Palpation. Abdomen was soft and non-tender. There was no any local rise of temperature. No liver and spleens were not palpable, and kidney were not ballotable. Percussion, tympanic note heard over the abdomen. There was no any shifting dullness or fluid thrills present. Auscultation, bowel sounds were normally heard. And the other systemic examination, respiratory system showed bilateral air entry equally present, and there was no any wheeze or crepitation. There was no any respiratory distress, and lungs were clear, and normal vesicular breath sounds were present. CVS examination, S1, S2 heard normally, and there was no any murmur. CNS examination, child was conscious and oriented, and there was no any focal neurological deficits were present. Provisional diagnosis, frequently relapsing nephrotic syndrome with relapse with upper respiratory tract infection and acute gastroenteritis with mild edema.
Okay, you can proceed.
Investigation. At the time of admission, the serum albumin was 1.81 gram per dl, BUN was 6, serum creatinine was 0.2, and calcium was 7.7 mg, phosphorus was 3.19, sodium and potassium was 132 and 4.19. CBC showed 12,000 counts, 35 hematocrit, 6.6 thousand TLC, 79% neutrophil and 17% lymphocytes, and 4 lakh platelet count. CRP was 21. Urine RM showed a specific gravity of 1.027. Proteins were present 3 plus. 1 RBC counts per HPF and 4.7 pus cells were present. Stool examination was done. Blood was absent in the stool routine and microscopy. Mucus was present, 0 to 2 WBC per high power field, and no RBC. Stool biofire was sent that showed enteroaggressive E. coli. Blood culture was sterile.
Then how did you manage?
Sir, this child was managed with IV antibiotic, and for edema, just a salt restriction was done, and antibiotic was given.
Why antibiotics?
Ceftriaxone was given, sir.
No, no, why antibiotics were given?
Sir, because initially the child was presented with fever, and till the till the blood culture was pending, antibiotic was given, and after the provisional report was available, the antibiotic were stopped.
All right, then any diuretics were required?
No, sir, diuretics was not given. Albumin was given, sir.
All right. And then how about steroids?
Steroids were given in the stress dose only, and it was not given at a full doses. It was given just a point 0.5 mg per kg per day.
Anything else in the management?
No, sir.
All right, you can proceed. Okay, now you are coming to the
Sir,
sort of
now discussion part is there.
discussion part. All right, then we go back to your management. And why do you call it a frequently relapsing nephrotic syndrome?
Because, sir, at present, child did not have multiple relapses episode, but in the 2022 to 2024, child was having 5 to 6 relapse episodes that was fitting in the frequently relapsing nephrotic syndrome definition.
In other words, what is the definition of frequently relapsing nephrotic syndrome?
Sir, if child is having uh, two or more than two episode in the initial 6 months after the completion of treatment or during the therapy, if child is having two or more relapse, or three or more relapse in the any 6 months duration, or four or more relapse in any 1 year period, so it was called as frequently relapsing nephrotic syndrome.
So this patient, according to you, fitted into the category of frequently relapsing nephrotic syndrome. Okay.
Yes, sir. Previously it was
So,
fitting, but from last 1 year, child did not have multiple relapse episodes.
all right. Then you have mentioned that the child was given cyclophosphamide also.
Yes, sir.
So let's say you have a patient who is having frequently relapsing nephrotic syndrome. He
Yes, sir.
comes to you, and by definition, he is actually frequently relapsing. So how do you manage such patients?
Sir, usually in the frequently relapsing nephrotic syndrome, we can manage with the steroid. If it is steroid sensitive, then and in that case, we will give alternate day steroid therapy for prolonged period, which is zero point 0.5 to zero point 0.7 mg per kg per alternate day, and the therapy was continued for 6 to 12 months. And if child will maintain a remission for the sustained period of time, then we can reduce the dose to zero point 0.2 to zero point 0.3 mg per kg per day.
Right. That means you can reduce the dose as much as possible.
Yes, sir.
So maybe it can be reduced to zero point 0.1 or zero point 0.2, maybe zero point 0.3, maybe zero point 0.4, but you want to reduce it, okay?
Yes, sir.
So you give it for around 6 months to 12 months.
Yes, sir.
And if the patient behaves well, there are no relapses, that is fine. But in
Yes.
spite of your giving zero point 0.5 milligram or zero point 0.7 milligram per kg alternate days, the patient relapses. So then what will you do?
If despite the adequate dosing of steroid and on alternate day basis and for prolonged period and still child relapses, so in that case we can give a steroid sparing agent like levamisole, mycophenolate mofetil, and cyclophosphamide.
How do you decide
And
which sparing agent to be given?
for that, we can decide based on the steroid threshold if it is more than 1 mg per kg, or if child had any complicated relapses, or if child had developed any steroid toxicity feature. So in that case, if child had developed any of the following, so we can start with the high dose of mycophenolate mofetil or cyclophosphamide, and if nothing was present out of all the three, then we can start with the levamisole or mycophenolate mofetil.
That means what you are trying to say is if the problem is milder one and the steroid threshold is if it is not more than 1 milligram per kg on alternate days, there are no complicated relapses and there is no significant steroid toxicity, right?
Yes, sir.
So in those situations, you will like to give either levamisole or mycophenolate.
Yes, sir.
And if all these in any of these situations are present, then you would like to give mycophenolate or cyclophosphamide.
Yes, sir.
Okay. So in this patient, you chose to give cyclophosphamide.
Yes, sir.
What was the reason?
Uh, Sir, exact reason.
You just mentioned three conditions. One is steroid threshold more than 1 milligram per kg, or a complicated relapse, or steroid toxicity significant.
Yes, sir. So, sir, probably, sir, it is because of the high steroid threshold, because child does not have any steroid toxicity feature, and child did not have any complicated relapses. So, most
Steroid
probably,
toxicity is at present what you have examined. He was giving cyclophosphamide much earlier. So
yes, sir.
we don't know. After giving cyclophosphamide, he improved and he didn't have many relapses. And at present, there are no features of toxicity, but
Yes.
probably at that time. Mm. And was low dose steroids were tried in this patient?
No, sir. As per mother, it was not given.
Probably the records are not clear because, as you have mentioned, that
Yes, sir.
the first thing which is being done for such patients is that you give low dose alternate day steroids, and still, if there is no response or the expected response, then you go on to either levamisole, mycophenolate, or cyclophosphamide. So
Yes, sir.
probably this child might be having some complicated relapse or maybe had significant steroid toxicity for which cyclophosphamide was given, and he responded to some extent for some time. Right?
Yes, sir.
Then, supposing he doesn't respond to mycophenolate or cyclophosphamide, then what will you do?
So, in that case, it was considered as a difficult to treat nephrotic syndrome, and in that case, we can try calcineurin inhibitor, cyclosporin or tacrolimus.
So, in that case, probably you will need a biopsy also before CNI or no?
Yes, sir. Yes, sir. Before starting CNA, we will do biopsy, and then we will put on cyclosporin or tacrolimus.
Right. So let us go on to certain basics that you made a diagnosis of nephrotic syndrome. How do you define it?
So, nephrotic syndrome is defined based on the three criteria, and all of them must be present. One is massive proteinuria, which is defined as urine protein UP by urine protein to creatinine ratio 2 mg per mg, or if the urine protein is more than 40 mg per kg per meter square, or if the urine protein is by dipstick method, if +3 or +4 is there, then it is considered as a massive proteinuria. And another is hypoalbuminemia, which is less than 3, serum albumin level is less than 3 gram per deciliter, and edema must be present.
You see, previously the definition included hypercholesterolemia also.
Yes, sir.
So that has been omitted. And you see, sometimes edema may not be present. So maybe you can say that it is not very essential to diagnose. So one important thing is it's a massive proteinuria. One most important criteria, that is massive proteinuria, which you have defined. And edema, you see, if supposing the patient is having loose motion and vomiting also, so he is losing fluids from
Mm.
there. Maybe when he presents, he may not be having any edema. Or even we have seen many patients who are having a low serum albumin, but still they don't have any edema. So although definition mentions edema, but sometimes we see patient with without edema also. Okay,
Yes, sir.
and then okay, then you can go on to the discussion, and then rest of the things we can discuss there.
So, definition: heavy proteinuria, urine protein 3 plus or 4 plus or 1 gram per meter square per day, or if more than 40 mg per meter square per hour, or spot UP by UC ratio is more than 2 mg per mg, or albumin is less than 3 gram per deciliter, and if edema is there. Incidence is 1.2 to 16.9 per 1 lakh children, and the usual age is 2 to 6 years, but it can present between 1 to 12 year of age group. And before 1 year and after 12 year is an atypical age for nephrotic syndrome. Definitions: nephrotic range proteinuria, as we have discussed, and remission. If urine protein is nil or trace and UP by UC ratio is less than 0.2 mg per mg for 3 consecutive early morning specimen, then it was considered as remission. And in relapse is considered when UP by UC ratio is more than 2 or urine protein is 3 plus or more for 3 consecutive early morning specimen and having been previously in the remission. Frequent relapse is defined as 2 or more relapse in the first 6 months after stopping initial therapy or during the therapy, 3 or more relapse in any 6 months period, or 4 or more relapse in 1 year period. Steroid dependence is defined as 2 consecutive relapse when child is on alternate day steroid therapy or within the 14-day of its discontinuation. Steroid resistance is defined as lack of complete remission despite the therapy with daily prednisolone at the dose of 2 mg per kg for 6 weeks. Stable remission means sustained remission or infrequent relapses during the immunosuppressive therapy. Complicated relapse means a relapse that is associated with life-threatening complications like hypovolemia that requires inpatient care, severe infections like peritonitis, cellulitis, meningitis, or thrombosis, significant toxicity like hyperglycemia, which is defined as fasting blood glucose more than 100 mg, or postprandial glucose more than 140 mg, or HbA1c more than 5.7. Obesity, if BMI is more than 27 kg per meter square adult equivalent. Short stature, height is if height is less than 2 standard deviation and height velocity is less than 3 standard deviation. Raised intraocular pressure, cataract, myopathy, osteonecrosis, or psychosis. Difficult to treat steroid sensitive disease if both of the following features are present, like frequent relapse or infrequent relapse with significant steroid toxicity, and failure of 2 or more than 2 steroid sparing agent like levamisole, mycophenolate mofetil, and cyclophosphamide. So nephrotic syndrome, 90 to 95% is primary or idiopathic, and only 5 to 10% have secondary causes. And out of the primary nephrotic syndrome, 80% are because of the minimal change disease, and 7 to 8% are because of the focal sclerosing glomerulonephritis or mesenteroproliferative glomerulonephritis. In secondary causes, the systemic illness like SLE, HSP, polyarthritis nodosa, diabetes, amyloidosis, or malignancies like leukemia, lymphoma, infections, hepatitis, HIV, EBV, malaria, congenital toxoplasmosis or syphilis, or familial diseases like Alport, congenital nephrotic syndrome, sickle cell disease, Fabry disease, and drugs like NSAIDs, heroin, penicillamines, gold, and lithium. If child is presenting as a first episode of nephrotic syndrome, so if suspected, if there is any secondary cause is suspected or alternative diagnosis is suspected, so based on that, the investigation needs to be done. And if it was not suspected, then child can started with prednisolone at 2 mg per kg daily dose for 6 weeks, and if remission, then 1.5 mg per kg on alternate day for 6 weeks. There is no need of tapering of steroid. And if there is any partial remission or no remission, then we need to refer to the pediatric nephrologist. The investigation in the child with nephrotic syndrome, the essential investigation that needs to be done in the all child presented with the nephrotic syndrome are urine analysis, urine routine and microscopy, and quantitative estimation of spot urine protein by spot UP by UC ratio, CBC, and blood urea, creatinine, electrolytes, total protein and albumin, and cholesterol level. Tuberculin test needs to be done in all the patient to rule out the tuberculosis infection, and additional evaluation is based on the indication only. So if any gross or persistent microscopic hematuria, sustained hypertension, or if AKI without hypovolemia or any secondary causes is suspected, so in that case complement level C3 C4 ANA and ASO titer needs to be done. And if there is any history of jaundice or any liver disease, so for that serum transaminases and hepatitis B, surface antigen and anti-HCV needs to be done. Chest X-ray if tuberculin test is positive, or if there is any history of recent contact in the past 2 years, or if any lower respiratory tract infection is suspected. Edema. For edema, we need to assess for the hypovolemia, and based on that assessment, treatment is decided. And also, prednisolone therapy needs to be started. So for hypovolemia assessment, it was assessed by clinical feature and biochemical methods. Clinical features like abdominal pain, vomiting, lethargy, and CRT is prolonged, or if there is any cold extremities. If tachycardia is there, low volume pulse is there, a blood pressure is low, and postural hypotension is there, and biochemical indices like elevated hematocrit, blood urea to creatinine ratio is more than 100, fractional uh, fractional excretion of sodium is less than 0.5% of, or urinary potassium index is more than 0.6, or ultrasonography showed decreased IVC diameter or increased collapsibility index. So these are the features that are suggestive of hypovolemia. If any of the feature is present, so in that case, IV bolus needs to be given 10 to 20 ml per kg over 30 minutes, and repeat if child is still hypotensive, and then start with the IV or oral hydration and IV albumin 0.5 to 1 gram per kg over 4 hours. And if there is no hypovolemia, then assess the edema as per the criteria. If the weight gain is less than 7%, then dietary salt restriction is enough to manage the edema, because steroid will also reduce the edema over the 5 to 7 days. And in moderate to severe edema, if body weight is more than 7%, so initially dietary restriction needs to be done, and oral furosemide is the drug of choice for edema, which is given in the dose of 1 to 4 mg per kg per day. And if more than 48 hours furosemides is required, so spironolactone can be added. So it has potassium sparing effect. So, and if child does not respond to the furosemide, so in that case hydrochlorothiazide or metolazone needs to be added, or we can start IV furosemide in the dose of 1 to 2 mg per kg per bolus, that can be repeated twice per day, or after the bolus infusion needs to be started at the dose of 0.1 to 0.4 mg per kg per hour. And if child does not respond, then we need to give IV albumin over 4 hours 0.5 to 1 gram per kg, followed by IV furosemide 1 to 2 mg per kg at the end of infusion. And if it is refractory still, so in that case ultrafiltration or CRRT needs to be done. in the child with relapse. So in the initial relapses, the dose of steroid is 2 mg per kg daily until remission, and then 1.5 mg per kg on alternate day for 4 weeks. Infrequent relapses are treated in the same way, but infrequent relapse, or if child does not respond till the 6 weeks of daily steroids, so it was considered as a late steroid resistance. So frequent relapse and late steroid resistance are referred to the pediatric nephrologist. And frequent relapse or steroid dependent nephrotic syndrome. In that case, they are treated with the prednisolone on alternate day, and it was given daily during the infection period. And still, child is having relapse episodes while child is on alternate day therapy, or child develops any steroid toxicity symptoms. So we need to assess for the non-steroid therapy, non-steroidal agents. And for that, if steroid threshold is more than 1 mg per kg or alternate day, or if child had any one or more than one complicated relapse, or if steroid toxicity is present, so for that cases, they needs to be managed with the mycophenolate mofetil or cyclophosphamide. If nothing was present, then they can be managed with the levamisole or mycophenolate mofetil. And while started with the levamisole or mycophenolate mofetil, and if still develop relapses, so they are treated with the mycophenolate mofetil or cyclophosphamide. And if they do not respond to that, so they are considered as a typical to treat diseases, and they are treated with the calcineurin inhibitor. And if child showed no response to the calcineurin inhibitor, then rituximab can be given. The complications in the nephrotic syndromes are hypoproteinemia, malnutrition, anasarca with ascites, or serious pleural or pericardial effusion. Serious infections like peritonitis, pneumonia, cellulitis, bone and joint infection, or meningitis. Flare-up of tuberculosis while child is on immunosuppressive therapy. Severe hypovolemia, acute kidney injury, especially when they are complicated by gastroenteritis or uh, infections. Thrombosis, venous thrombosis are more common, arterial are rare. Generally, it involves the major vessels like renal veins, cerebral venous sinuses, or deep venous sinuses. The indication of kidney biopsy in nephrotic syndromes are persistent microscopic hematuria on three or more than three separate occasions, and gross hematuria is there. If AKI, despite the correction of hypovolemia, if systemic features is there like fever, rash, arthralgia, or any other secondary cause is suspected, if low C3 level is there at the start of the treatment or at the time of the diagnosis, initial or late steroid resistance prior to therapy with calcineurin inhibitor, and if the CNI is given for more than 30 to 36 months therapy, and if GFR is reduced while ongoing treatment, so they are the indication for kidney biopsy. Light microscopy and immunofluorescence needs to be done in all the biopsy. Electron microscopy based on the availability and suspected lesions. Immunization. If child is receiving high
think,
dose bread,
Dr. Dixit, you can
yes,
just
sir.
go through these salient features.
Okay, sir. If child is receiving a high dose prednisolone, which is more than 2 mg per kg per day, and the duration is less than 2 weeks, so child can be vaccinated once the treatment is discontinued. Or if the duration is more than 2 weeks and child is receiving high dose steroid, so Once treatment is discontinued, 1 month gap is required to vaccinate with the live vaccines. And if child is receiving low dose steroids, so vaccination can be done once the treatment is discontinued. If child is on alternate day steroid therapy, and if there is an urgent need for vaccination, so in that case live vaccine can be administered. Otherwise, once the treatment is discontinued, vaccination can be done. And if a child is receiving cyclophosphamide, so 3 months gap needs to be done. And if child is receiving any other agent other than cyclophosphamide and steroid, so all of that require 1 month gap. In rituximab, 9 months gap is required uh, after the treatment. And in immunocompetent siblings or household contacts, they are refrained from administering the oral polio vaccine, and MMR, rotavirus, and varicella vaccine can be given for all the household contacts. And for the child himself also, influenza vaccine can be given annually. Pneumococcal vaccine, if child is falling in the age group of 6 months to 72 months, and if child is completely immunized, so 1 dose of pneumococcal conjugated vaccine can be given after 2 years of age. And polysaccharide vaccines, 1 dose after the 2 years of age and after 8 weeks of the last dose of conjugated vaccines. And if child is not immunized or partially or incompletely immunized, so in that case 2 doses of conjugated vaccines are given 8 weeks apart. And polysaccharide vaccines, 1 dose is given after the age of 2 years and 8 weeks apart from the last dose of conjugated vaccines. And if the age of the child is more than 72 months, and if child is completely immunized, then only the polysaccharide vaccine is given 1 dose only. And if it is not immunized or incompletely immunized, then 1 dose of conjugated vaccine is given, and 1 dose of polysaccharide vaccine after the 8 weeks from the last dose of conjugated vaccine can be given. Varicella vaccine can be given if the child did not have any chickenpox, documented chickenpox infection in the past, if child that does not receive 2 doses of vaccines, or if serological evidence of immunity are absent. So in that case, varicella vaccine can be given as 2 doses 4 to 8 weeks apart after the age of 15 months. Influenza vaccine annually can be given after the 6 months of age. And hepatitis B vaccine is given in the double dose, and the usual dose is 10 microgram or 0.5 ml. But in case of nephrotic syndrome, it is given as a double dose, which is 1 ml, and 3 doses are given at the age of 0, 1, and 6 months. The gap between the first and second dose is 4 weeks. The gap between second and third dose is 8 week, and first and third dose is 16 week or more. And if vaccination, if the antibody titer anti-HBs is less than 10 milli international unit despite the vaccination, then the vaccination or additional doses needs to be given.
Thank you, Dr. Dixit.
Yes, sir.
You have done quite well in your presentation. And one last question from my side, because once you are giving steroids for a longer period of time, especially in frequently relapsing nephrotic syndrome, so you have to look for steroid toxicity.
Yes, sir.
So, what are the features and how often you should monitor them?
Sir, steroid toxicity feature, the like hyperglycemia can be there, which is suggested by fasting sugar is more than 100, or if postprandial glucose is more than 140, or if HbA1c is more than 5.7. Hypertension can be there. Short stature can be there. Height will be less than 2 standard deviation, or height velocity will be less than 2 standard deviation. Or if child develop any osteonecrosis or any fracture, child develop any glaucoma, or if child develop like Cushingoid facie or moon-like facie. So all of these are features of steroid toxicity.
Myopathy,
Myopathy, yes, sir. Myopathy, osteonecrosis,
mhm.
and any
Psychosis,
behavioral changes like
behavioral changes
psychosis.
maybe, psychosis, okay. Increased intraocular pressure.
Yes, sir.
So how often, supposing the child is on steroids, so you have to refer them to a ophthalmologist to look for cataract, although we can also look for it, but since there are specialists available, then they have to check for intraocular pressure also. So how often that should be done?
Sir, usually after 3 to 6 months period, we can do the ophthalmology check
Right,
for
every
intraocular pressure.
roughly every 6 months. Okay.
Yes, sir.
And rest of the things you see whenever they are coming to the hospital or the clinic for a checkup, then rest of the things like weight, height, they
Yes,
can
sir.
be
Growth
checked at
parameter.
every visit. And
Yes,
anytime they have features of myopathy or psychosis, then definitely that indicates that there is steroid toxicity.
yes, sir.
Or let's say in terms of dose, how much dose if a child has received, then we can think that this child may develop features of toxicity.
So usually if child receives more than 200 mg per kg per year cumulative dose, so in that case there are higher chances of developing steroid related toxicities.
That means any child has received around 200 or even sometimes less, 180 to 200 milligram per kg, then one should be very careful and should be doing all these parameters very carefully. So the dose has also to be calculated, how much the cumulative dose has been or the child has received during the last 1 year. Okay.
Yes.
So one final thing, what is the prognosis?
Sir, in steroid sensitive nephrotic syndrome, the prognosis is good, and is as the child grows, then the frequency of relapses are reduces, and around 10 to 20% will come out of it, and 4 4% to 45% children will continue in the adulthood also, and hardly 1% or less than 1% will develop renal failure.
I think going into the adulthood, 4% may be little high. So 1 to 2%, right?
Okay.
Okay, then I think that's all. Thank you very much.
Thank you, sir.
And Gaurav, can we conclude?
Yes, sir.
Okay, then thank you, all of you, and we conclude the session.
Thank you, sir.
Thank you, sir. Good night, sir.
Thank you.